TB remains a public health problem in Zimbabwe, with an estimated TB incidence of 204 cases per 100,000 population. We are double burdened with TB and HIV co-infections and drug-resistant TB.
This 5-year funding support pretty much was to support the country to find missed persons with TB, linking them to care, as well as addressing key population groups that are affected by tuberculosis across 8 priority districts in the country.
The role of the Union Zimbabwe Trust in the TB consortium was to provide administrative and technical oversight. We had a set of experts, technical experts in PMDT, in childhood TB, TB-HIV, as well as M&E sections.
Mwana akanga asingagaini weight, asina ndichiti chero ndikaenda naye kuchipatara aingoramba akangodaro pasina chiri kumbochinja. Saka ndakangoendawo kuna mbuya clinic vanova health worker ari kuno kuRB. Saka pandakaenda nemwana kuchipatara ndakasvika ndikaona vana chiremba vakandiudza vakati nyaya iripo ndeyekuti mwana takutomuita matest kuitira kuti tizive kuti chiri kunetsa mwana chii. Saka pavakambata TB ipapo mwana akabva toiswa pamushonga. Saka mwana ndakaona kutochinja ari kuimprove, chikafu akanga asingadyi, even kuonda mwana akanga akangoonda zviya zvekuti waishauza kuti zvazvakatooma, but mishonga iyo yakaita kuti mwana wangu aite zvakanaka.
So part of the innovations that we have been supporting is establishing centers of excellence in some of these districts where healthcare workers were trained, and in particular on the use of stool as an important diagnostic approach to find TB in children. And we've seen a progressive improvement in terms of uptake of such innovative approaches, as we've managed to see some increase in the proportion of childhood TB cases diagnosed in the country.
Ndaka volunteer kuva peer mobilizer wema-miners koko. Saka pekutanga zvairema because ndaifamba ndichitanga kutaura nevanhu ndichivamobiliza ndichivaudza nezveprogramu iyoyo kuti kune chinoi TB, kune chinoi silicosis kwamuri kunyanya ma-miners.
Ndaikusura nekunzwa mabayo nekuzarigo, ende kana wava usiku paya kana wavata waisweta zvisingaiti. Saka ndakabva ndarangarira imwe organization yaiitiwa yekutestiwa kweTB yandakanga ndambonzwa navanonzi maibhanda. Ndakabva ndavavinga mumba kwavo. Ndasvika kuna maibhanda ndakaudza nyaya yangu, saka vakwanisa kutibatsira nemari yetransport. Ndikauya ndikazotorwa chikarahwa ndikaenda kuX-ray. Zvese zvakaitwa pachena pasina mari yandakakwanisa kubvisa. Mari dzacho akati neTB ndakakwanisa kupiwa treatment yangu.
The role of Baines in the Kunda-Nqob'iTB project was first to operationalize and institutionalize TB screening integrated into the occupational health front within the project districts in the 3 provinces. So Baines has been involved quite significantly in terms of institutional screening of tuberculosis, as well as capacity building of healthcare workers in the field of occupational lung diseases. And more importantly so, Baines has been involved in carrying out workplace-based screening activities for TB and occupational lung diseases. And the innovation here has been taking the screening services to the work site, so that there is reduced time off of the workers, and also they can also guarantee the safety of their hours without having to travel all long distances to the nearest health facility. That has been a game changer.
Kunda-Nqob'iTB
when it came, I was trained in DR-TB case management and also TB-HIV-DM integration and childhood TB. I was also attached to Neshuro District Hospital, a center of excellence, where I was trained in the care and management of childhood TB. In relation with the case that we have here, we have got Ivy Ruvarashedondo, who was diagnosed with DR-TB. So it was easy for me to manage a case. From the TB-DM-HIV integration, I knew that there was something wrong with this case because she had malnutrition, RBS was also a bit high. So we thought of testing her for TB. That's when she came out to be the results came out to be drug-resistant TB.
Ndakabenefita zvakare kubva ku feedback yema-workshop akaitwa akafanana ne making sense of TB data ne palliative care. Now I can now compile TB data and verify TB data ndichiproduce a quality TB data. Ndakwanisa kuitawo gastric lavage, ndakwanisa kucollecta stool kuvana tichidiagnose TB. Zvakare Kunda-Nqob'i yakandibatsira paku prisuma TB ne-STEM strategy. Mafigures edu increase ku prisuma TB nama-diagnosis acho.
And we also rolled out the STEM strategy, which is a strategy which allows for increased presumption because there's a greater index of suspicion at all entry points into facilities. Making sense of TB data is a course we are proud of, as we were the flagship through the union, and that has also assisted facilities to analyze their own data, to make decisions and to use it on their own. So it's a bottom-up approach in the way data is used.
Takabata TB 20 October 22 kazopedza 16 January 2024. Rwendo rwachona rwaisava nyore nemhaka yekuti panzvimbo yatinogara takati one day tine vavakidzana vakati one day dzimwe nguva tokwanisa kutotenga mvura panzvimbo imwe chete tobika panzvimbo pakaita one. Saka zvakati nonokei kuti vanhu vazvinzwisise kuti paitika nyaya yeTB nekuti vanhu vazhinji vanofunga kuti munhu akaita TB pane zvese zvatosanduka pakati pemararamiro ake. Asi kuburikidza nevillage yetu yatakapiwawo anonzi mbuya V-Conic vakauya vakatibetserawo vakataurawo nevanhu vatinogara navo vakwanisa kuvapawo ruzivo.
Pandakanzwa kuti Brighton naPamela vapinda pamushonga, ndakauya ndichivabatsira ndichivadzidzisa kuti zvofambiwa sei kuti vamwe mushonga wavo. Nekufamba kwenguva pakazoita problem yekuti vakazouya vakandiudza kuti havasina kugara zvakanaka nekuda kwekuti vanga vafesa stigmatization panyaya dzekuti as you see komboni yatigere vanhu vakanyanya kubatana vakawanda. So ndakauya ndikapa ruzivo ndikaunganidza next door neighbors avo because like kunoku mukaona zvatiri vanhu vanowacha pamwe chete vanobika pamwe chete saka papa kuva neproblem. Saka ndakauya ndikavadzidzisa ndikavaonesa vakazvigamuchira nokuti vanga vasina ruzivo. Saka zvakabva zvatoita zvakanaka.
In terms of drug-resistant TB, we know that the outcomes for these patients has been poor. So we realized that despite the shorter treatment regimens, we had over-decentralized care for drug-resistant TB. So in the Care and TB program, we re-centralized alongside the Ministry of Health, where we had fewer sites that were providing treatment to drug-resistant TB patients. And we came up with site-based capacity training, where we're able to train a team instead of individuals who are then supposed to cascade to their facility.
CPV wasinceda ngokuzocheka vukani lidle nata amaphilisi esikhangela nje esincedisa ukuthi yasikhumbuze ukuthi lingakhohlwa isikhathi senu konke nje njengakonke.
Lami njengo-CPV wakhe osebenza la ngoba ngangenza i-training yobu-CPV Singaqala nje ukuvuka ke ngisize ekuseni ngisenze education labo egumeni ngibafundisa nje lapha nalaphana ukuthi hayi kumele lenze kanje. Kumele lenze kanje linathe ngesikhathi amaphilisi. Linatha amaphilisi ngendlela lithola ukudla okwakha umzimba okuzahambelana lamaphilisi.
So our role in terms of community interventions was looking at ensuring that we raise awareness, we create demand for TB services, we train community-based volunteers. Community-based volunteers would then in turn they also facilitate active case finding, but also we were using a hybrid contact investigation approach where the community-based volunteers were working with the EHTs and the local facilities to ensure that people are put into care. But post them being referred into care after presumptions, they would then also follow them up. And as they were following them up, they would then use direct observed treatment methodology to ensure that adherence is facilitated. Most importantly, the community contribution increased from baseline in 2019 from 8% to 25% in 2023, which was a remarkable achievement.
I-Palliative ngayithanda kakhulu ngoba isebenzisa kakhulu i-spiritual support, isebenzisa kakhulu i-social support, isebenzisa kakhulu emotional support.
Palliative care relieves suffering and improves quality of life or quality of care for patients with any life-threatening illness such as TB.
Uhlelo lwe-Palliative lwabusisa kakhulu abantu. Ngiyabona kudala mina ukuze ngesabi ngambona abantu be-TB bethwala nzima begula benjani bengazwisise ukuthi bahamba njani, kodwa once kwaphipha in i-palliative care ayi khathesi umuntu we-TB ungaphambana laye njengo-HIV ungazi ukuthi ule-TB.
With palliative care within the TB KNTB program, we wanted to capacity build people who were looking after the patients. And we started by capacity building health professionals who later cascaded the training to community cadres. But for them to do that, we needed to develop manuals and tools. And therefore, within this project, we developed TB manuals which integrated palliative care in it. And we also developed tools to make sure that the cadres have tools to use while they are doing their work.
As we wrap up this program, we are excited to note certain key achievements that we've realized over the last 5 years. Firstly, through our community healthcare workers, we've been able to reach over 1 million of our community members in these 8 districts with TB messages, screening them, and over 50,000 were referred by these community healthcare workers to the nearest health facility for TB screening and further evaluation.
So the KNTB project contributed significantly in the reduction of the TB incidence over the years, from as high as 242 per 100,000 to 204 per 100,000 in 2022. And it also played a pivotal role in reducing the burden of HIV in TB patients from 62% in 2015 to 50% in 2023.
Ngithi long life izalicelela ukuthi impilo yeni yekhatshana lingisiza i-community zonke.